Hi, everyone. Welcome back from break. Our next session is going to be called Outcome Measures, the Eras Tours. So as we heard a little bit in those opening sessions, you got to see some of kind of our more traditional outcome measures. These are the things that we use to help try and understand in clinical trials, whether drugs are working, if they're providing benefit to patients. They're sometimes used in the clinic as well to help understand disease progression. And as you heard from Pat in her opening, the research in Duchenne's always advancing and evolving, and outcome measures fall into that category as well. We need more sensitive outcome measures. We need outcome measures that are more inclusive to a broad population of Duchenne and Becker, and things that help measure other things than just strength. Quality of life is really important. So we have a really great panel that is going to talk about where we might be heading with some outcome measures and some newer outcome measures that are in development. And so this session is going to be led by Tina Duong from Stanford, who is a researcher and a PT, and we have a really great series of talks to go through this. So Tina, I'm going to hand it off to you for this session.
Great. Thank you so much, Eric. First, I'm really excited about this session, one, because it's about outcomes, and I heard people get excited about the Eras Tour. Apparently that's Taylor Swift. So we'll try to get a little bit of all things, but mostly because of the panel that I have who will be able to provide some insight on their work. I love their innovation, pushing the envelope on what we think is traditional. So I think we have a great 30 minutes or so for us to present what we have, what's to come, and how that may impact the landscape that we have today. As I said, we'll start. We're not going to disappoint. So this is the Eras Tour, so get ready. There'll be a few snippets in between each talk. So, as we talk about outcomes, a major difference between a well-developed science and some of the less well-developed science is the degree in which they are measured. And so with that said, how are we currently measuring outcomes? We talked a lot about the traditional measures. I was asked to talk about Northstar and Pool. Tradition is not really my thing, so I would like to really spend most of the time to think about outside the box. But that being said, we understand this is what everybody has seen in regards to assessments. In the circles, I have highlighted where the gaps are, even just in the measures that we're looking at. If you look at the spectrum of the disease, most of the outcomes that we've studied exist in the 7 to 14, 15 area where we're studying ambulation. As studies are being done in younger and younger kids, do we really truly know what the Northstar means in a 4-year-old compared to an 8-year-old? And that's the question we have when we say a scale is validated. The Northstar is validated. It is, but the question is, in what patient population? What's the context of use? So I want to frame our discussion today with keeping this in mind as we talk about some of the other outcome measures. And then we don't want to leave out other people. We are mainly physios and people who care about movement, but there are other gaps. And I've just kind of laid out, a roadmap of other gaps that we really need to talk about in regards to outcomes, because I don't want us to only think about motor outcomes, because when we're looking at studies and study design, how can innovative approaches to how we look at outcomes or other options of outcomes really address inequities, the diversity that we really need in our clinical trials to better generalize our findings. So here's the meat of the matter. Most everyone here is going to talk about movement. So what's the context of use in some of the movement that we're assessing for outcomes? We want to look at the quality of movement. So what you'll see is that a lot of the panelists here will describe compensations and how people or children are moving. So there could be movement imbalances, there could be synchrony or asynchrony of movement that looks at the quality, as well as describing how a person moves, whether it's gait kinematics, because at the end of the day, compensations cost, and it costs energy. And that energy results in fatigue. And so that's why it matters. So then what do we need? We need something that's sensitive and objective. Can we use technology to increase the frequency in which data is collected? Can it be collected at home? How do we do this to integrate real-world data to bridge that gap? It's easy to just talk about it, but the critical thing is feasibility. Can you do it? Will the patients do it at home? And how reliable is it? And then most importantly, when we talk about digital health technologies, it's the variable of interest. And I'm sure many of the panelists will talk about that today. You can get a ton of data, but what does that data mean if you can't put a pin on how it impacts a quality of life or function? So that said, I'm going to introduce you to the panelists today. First, we have Megan Iammarino. She'll talk about reachable workspace, some upper limb movement. She's from Nationwide Children's. Then we have Amber Sapp and Mindy Leffler, who will talk about the digital video assessment that can be done at home. And lastly, we have Laurent Servais, who will talk about the wearable side device, the 95th percentile. And I will open up with the OpenCap technology that we're working on and do an aimless plug of, if you're here for Saturday, please do come see us. We're doing video assessments. Anyone can do this, and as of yesterday, that includes people in wheelchairs. So please do come see us, and if you want, those of you who do not have Duchenne and want a video, please do come by. There's a QR code, and then you can learn a little bit more about some of our developments there. Okay? With that said, I will introduce you to Megan, and she'll take it from here.
Thank you. Okay, good. All right, so I'm really excited. So measuring quantity and quality of movement across abilities, across the age span is really what gets myself and my team excited. I'm excited to be here on this panel of experts today to talk about functional reach and our work in that area. So I don't really see very many, but of the boys, young men, young girls that we see in clinic or who have been through clinical trials, we have this conversation often about, what would you prefer to do? Do you want to walk for 6 of the longest, most boring minutes of your life, or play a video game? Do you want to sit at a table and stack cans, or do you want to play a video game? So shockingly, or not, the answer, overwhelmingly, was they would prefer to play video games. Video games are something that are kind of age agnostic, they're gender agnostic, and so we kind of used that idea and took that, something that is motivational, something that is practical and easy to use in a clinic, and we developed this workspace volume. So what active workspace volume is it's a video game that uses a avatar to measure the area around your body that you can access through reaching and leaning. So this is called our functional workspace area. So it's not just measuring arm abilities, but it's measuring ability to reach and lean as well. So that incorporates a lot of that trunk strength and that trunk movement as well. So what you do is you sit in a chair in front of a camera, a Kinect camera from the Xbox, and you play this video game where it asks you to reach and lean as far as you can in all of the directions around you, and then we measure that using and quantify that volume using that scale. We then scale it based on the size of your ulna. So if which projects or provides what we would expect you to be able to do if you just moved your arms around you like this and had full range of motion around your arms, and that then we scale it to and give you a % predicted of what we expect to do. So if you can move your arms all around you while you're sitting in a chair, then you should get a 100% on the assessment. If you can reach and lean out of your just basic base of support, then you would get something above 100%, and then it also scales down from there. So our goal is to objectively measure function on a continuous scale using this platform that can help that is encouraging and motivational and can help reduce variability. So what we've seen with our data, and there's been many iterations, and anybody who has been to our clinic, I guarantee you have played this. So we've had many iterations. One was we asked you to reach and kill spiders, squish spiders, and now we've kind of moved, and the technology has moved into you're on a spaceship, like you can see in the upper corner, and you are blasting aliens. What we found from our data is that not only can we differentiate with raw values and scaled values, healthy controls versus individuals with a score of Brook 1, a Brook 2, Brook 3, Brook 4, and Brook 5, all of these are clustered and can be are significantly different than each other. So we can quantify function across all of these ranges of abilities. And what is also really exciting is that we can also quantify people with similar upper arm abilities or upper extremity mobility between ambulant and non-ambulant patients as well. So it really does get that, it's a little bit more functional as it gets that trunk lean and that trunk movement into the score. So that is the spiel, but I will now show you a little clip of how we play the game.
This game is to test how far you can lean and reach.
I'll mimic it.
Push further. You're doing it.
And then we move to the
Hurry.
sides.
Lean and reach to the left.
And this person did a bad job because they're
Come
not
on.
leaning, but
Really lean and reach.
I think it was Linda.
This is perfect for Disney.
And then we move up. So the idea is to be something that is motivational as well as provide some feedback to the boys or young men
They're attacking on the other side.
and can be
Lean and reach with
exciting.
your right arm.
So there we go. We go to
Keep
both
on
sides. We actually also move forward in the game.
They moved up here. Keep going. Reach further.
You have the person giving you consistent verbal feedback that is consistent for everybody.
Reach forward to blast the alien.
And then what you get at the end is this report that gives kind of a depiction of the areas of volume that you're able to access, and then also your scores.
Great. Thank you so much. Okay. Next is digital video assessment. We'll start with Mindy.
Sure.
Oh, Mindy, you may want to.
This one advances,
Yeah.
so it stops the music. Okay. So I'm Mindy Leffler, and I am the mom of Aiden, who is 20 with Duchenne. When Aiden first participated in a clinical trial, the outcome that was in favor at the time was the 6-minute walk. And for him, even at 8 years old, he had the question of why people cared so much about his ability to speed walk. He's not really into walking for fitness at the time. And so even he was wondering about that. And so that led us as a family to start thinking about what could we quantify in Duchenne that would be more meaningful to people with Duchenne and their families. And Duchenne is a condition in which it becomes more and more difficult to move until you can't move anymore. And so I thought about the conversations that I had had with caregivers. And those were conversations like, I upped my child's steroid dose because he gained weight, and he stopped pushing his hands off his thighs when he went up the stairs. Or I was watching my son, and he went from eating like this, or like this, and then started eating like this. And I knew, because he was supporting his other arm under the wrist, that he was getting a little weaker. And so we thought, okay, we could quantify these incremental movements that we as caregivers all watch, and we all know what they mean. We could take them and build them into scorecards that would quantify their disease progression. And so this is essentially the way it works. We have families recording a whole group of tasks, and we have tasks that span kids that are walking, kids that aren't walking anymore, so we can do one analysis across the entire spectrum of Duchenne, or we can target just a small segment. Caregivers take these videos at home of everyday activities where they're not influenced by things like fatigue from traveling to the clinic for a trial visit. And then we have data monitors that watch them come in, make sure they're scoreable. And then we have physical therapists that score the compensations that are seen on those videos. And so essentially the question that we're trying to answer is, in a clinical trial, is the treated group acquiring these compensations at a slower rate than the placebo group? So we're trying to look in a really sensitive way, can we see what incremental changes that those boys are making? to see if that treated group is gaining them at a slower rate than that placebo group. And hopefully then we can do that with some good sensitivity over time. So I'm going to pass this over to my colleague Amber, who helped me develop the DVA, and she'll walk you through scoring to see how straightforward it actually works.
Thanks. So I'm going to show you a couple of videos that will walk through scoring together, and ideally, we want to hear your participation so you can see how easy it is to score these videos. And I'll first make a disclaimer that these videos we've taken from the recent FDA AdCom from Sarepta's gene therapy drug, so you've likely seen these videos numerous times. So on the left, I'll show you the video. On the right, you'll see the scorecard that we use for this specific task of climb 5 stairs. So first we want to take a look at, does the child have the ability to perform the task? And so we're counting, can he climb 5 stairs? And so in this case, we would say, yes, he can climb 5 stairs, and then the therapist would continue to score the rest of the card. So next, I'd like to take a look at the stepping pattern. So is he alternating his legs step over step to get up the steps? Is he doing kind of a step 2 pattern? Is he doing this pattern intermittently? Does anybody want to comment? 0 through 3? I'll help you out. Okay, so we're going to say this is a step 2 pattern intermittently. So he does that like step 2, then he does kind of a step over step for a couple, back to step 2. Next, we'll take a look at his upper body and how he's using that to help himself. And we can see he walks over to the rail and he uses one hand for support. Next, we'll take a look at how his body is positioned. So is he turning his trunk to face the wall or to help to bear weight through that railing? Is he doing kind of a side step up the steps? Does he have a really wide base of support? And you can see here he has a pretty narrow base of support. I can't actually see the bottom of this slide, but his compensations total up to, I think it was 33%, if anybody can see that. So we consider that a severity score. So that's 33% severe on a scale of up to 100%. 100% being you can no longer perform the task. So the next video, same child, same AdCom video that we've used here. And I think you can't look at this kid and say he doesn't look better. So we know qualitatively he's improved. But what's nice about the Duchenne Video Assessment Scorecards is that we can quantify that. And after all, that's what the FDA is after, right? They want data. And so we're able to take the scorecard and convert that to a quantitative measure. So we can see he still climbs 5 stairs. He no longer has that alternating, or that step 2 pattern. He's just alternating every single step. He's no longer using a handrail, and he's not compensating with his body to push up on the handrail or against the wall. So he's gone from a 33% severity score to 0%. And again, really, at the end of the day, these videos are going to FDA. They're already seeing these. They're helping to get drugs approved. But at the end of the day, the FDA wants data. They don't just want an anecdotal video that's captured without rigor or without standardized processes. And so that's what we really wanted to bring to FDA and to families who are participating in these trials. I know Mindy's son, my son, has been a part of many trials through the years. And some of those trials end with really ambiguous results. And at the end of the day, we don't know. Did the drug work? Did it fail because we didn't have the right measurements? Were we not looking at the right things? And we really want to get those answers to families and to researchers. In a disease where we don't have much time, we want to get those answers faster. So, thank you.
Great. Thanks. Next up is Laurent.
Yes. Thank you, Tina. I was a little bit concerned with the first emails because you spoke about ERA tour, and I had no idea of what it is. So I had to go to Google, I confess. And then Tina said, oh, we should all come with shiny and sparkling clothes. So
and red lipstick.
So that's what I did, actually. So I found my most sparkling and shiny T-shirt. But this one, right? So that's the most shiny and sparkling T-shirt I could imagine. I'll start with 3 questions for you guys. How do you track a rocket if the enemy can spoil the GPS signal? You have to navigate without GPS, right? If a fireman goes into a building that is burning, GPS does not work indoor. You will need to track this man without a GPS because he is risking his life to save the life of others. We need to know where he is in the building, and we cannot use a GPS. And if you're tracking a spy, but a clever one, a smart guy, is able to disconnect, to switch off the GPS of the car. You need to track this guy without a GPS. So navigation without GPS makes a lot of sense for many superheroes. But then they need a superpower. And the superpower that the superheroes use, actually we have a lot of superheroes in the room and around who are using a similar superpower. It's a sensor. It's a simple sensor that you can wear at your ankle or at your wrist. And it's not a Fitbit. It's not an Apple Watch. It's maybe not as beautiful as a Fitbit or an Apple Watch, but it's a big difference. It's a medical device. It is something, when it records a stride of 90 centimeters, it is 90 centimeters. Except in the UK, where they used to count with metrics, I don't understand. But if it says 90 centimeters, it is actually 90 centimeters. And we will analyze stride per stride, identify every single stride. And if the patient is non-ambulant and use his superpower at the upper limb, we just record any single movement of the patients, and we quantify any single movement of the patients. And we don't ask the patients to do anything. We just ask the patients to live his life, to do what he wants. Because what we are interested by is what the patient is actually doing in his real life. Because that's what the drugs are supposed to do, to change the life of our patients. So the data, they go in the cloud, right? And then, as I said, we're going in ambulant patients, because I've been asked to speak about the stride velocity in 90th percentile, so that's mostly for ambulant patients. We will identify every single stride, and we will measure every single stride. And what are we going to do with that? We can do a lot of things. We can figure out if our patient runs. We can figure out if our patient falls. We can see if our patient walks fast or slow. But the outcome that has been qualified, and that has been qualified by European Medical Agency, is actually what we call the stride velocity 90th percentile. It means actually the 5% most rapid stride done by the patient. So we will consider what are the 5% most rapid strides. What is the top performance of the patients? Spontaneously, during 1 month. What is he doing? What is the top performance? And this is an example of what we can actually measure in a patient. You've got it. Well done. So we see the patients, oh, what happened? He falls. He stands up, and he continues walking. So we can actually identify every single stride. We can identify falls. We can identify stair climbings. We can identify if the patient climbs stairs like this or like that. We can measure the velocity of stair climbings. We can measure the velocity to raise from floor. And we can measure the stride velocity 90th percentile. So the regulators in Europe were happy to qualify that. And it was the very first time that any regulator qualified a digital outcome. We just published in Nature Medicine the first results. And you probably know, many of you in the room, that this is now a measure that is used across a large number of trials in Duchenne, because it has been demonstrated to be highly reliable and highly sensitive to change, positive change or negative change. And then I'm going to tell you what what's my dream? My dream is that I have two dreams. Well, I have many more, but for that I have two dreams. The first one is, do you know what I'm doing now? I'm not giving a speech, I'm not giving a lecture. I'm actually taking part in a clinical trial. Look, I've got my superpower. I'm taking part of a clinical trial. I'm not going to the hospital. I'm not traveling. I'm not spending my life in the airport, waiting hours on the tarmac of Orlando Airport. I'm not spending my life trying to find a parking place close to the hospital. I just live my life. This opens the possibility to remote monitoring, to remote evaluations, to decrease the number of visits of patients in the trial. And this opens the possibility of individualized follow-up. And my second dream is the toddlers. How do you assess a toddler? It's so difficult. You know, all of you, if you know a toddler, you know it. Ask a toddler to do something, he will not do it. Ask the toddler to do something the way you want him to do it, he will not do it. And ask him to do it again, he will not do it again. But if you put a sensor on a toddler and you tell the toddler, do what you want, I don't care, during 1 month, sooner or later the toddler will make his top performance. And then 1 month later, you tell the toddler again, do what you want, I don't care, live your life. He will do it. And he will be highly reliable, and he will make his top performance. And now my PhD student, they told me, okay, let me do what I want, I will be highly reliable, and I will make my top performance. Well, no, it's just for toddlers. Toddlers are incredibly compliant, much more than teenagers. They like it. They are highly reliable. We have a reliability that is insane in our toddlers. And the most important is that toddlers with Duchenne, 2 years old, are already very different on controls. Now we are actively collecting a lot of data on toddlers, and I'm confident that it opens the possibility to come to clinical trials much earlier on, at a time when the muscle is still in a very good shape, and to have a readout, a functional readout, that is available at the age of 2. That's what is stride velocity 90th percentile. Thank you for your attention.
Thank you so much, Laurent. So, we have our own Travis Kelsey, I think that's his name, here. We'll take a few questions. I have a strict order to make sure we end on time. So we have a few minutes, and so if you have questions, please do come up to the mic. But in the meantime, I would love to start. So listening to everyone, I'm very excited about all these things. I was on a panel with the FDA, and one of the things they mentioned about digital health technologies is that it must also be integrated in natural history studies. And so, you can see myself there. So I have a two-part question. Really, one is to the panelists: are the devices in which you're working on, are they in natural history studies? And if not, are there plans to get them in natural history studies? And then two is the translatability of it. I think it's great that we work on clinical trials, and these outcomes are great for clinical trials. They may be more sensitive and more reliable, and we can do it at home, but if I am the clinician having to write to the insurance companies and to argue for a patient to get access to a drug, how am I able to use this data, or can I use this data in order to fight that fight? Because what we've learned in some of these gene therapies is that the barrier sometimes to access is the payer. So, Mindy?
I'd love to start if you don't mind. So we have the DVA actually in a 150 patient study called ARISE. Some of you actually might be participants in that, so thank you very much for doing that. We're in FDA's qualification pathway. We've just submitted our qualification package to FDA. So this study, 150 patients spanning, very young boys all the way up to non-ambulatory boys with very limited arm movement, is we think the last bit of data that we'll need to hopefully get us the data for our FDA qualification package. So yes, we are in a natural history study as well as several interventional studies, so both contexts. When we envisioned the DVA, we hoped that one of the uses for it would be potentially to increase accessibility of care to people in remote areas as well, because you can envision a family could take this series of videos and then a clinician in one of the kind of magnet centers for Duchenne could evaluate those and then provide guidance to that family in a way that, you know, prevents the family from having to travel to clinic, because there's a lot of us, you know, that can't fly to Worcester or Columbus or wherever. So our hope is that, you know, it could provide access to really good quality of care to some of those families. So that was part of the goal as well, to use it in that context. And I think from the payer's perspective, I mean, I have a personal anecdote about that, which is that, you know, when we were trying to get coverage for my son on an approved therapy, we were actually able to find an avenue to provide these videos to my payer and got an overturning of a denial without having to go through the appeals process. Because I think there's a visceral impact to watching those videos when you see change in that ease of movement that the payers can visibly see. So taking that visceral impact and then backing it up with quantifiable data can be impactful.
Absolutely. Megan?
Yeah, so the active workspace volume is included in a number of natural history studies now, which is exciting, primarily in limb-girdle muscular dystrophies, and BCP disease and other neuromuscular diseases. But we have done a lot of work in Duchenne, and that was kind of the population that we started and developed this for. And as far as accessibility goes, we have gone down from, we used to have this big giant cart that had one of those big TVs on it, you know, and we had like a full system, and I would have to try and lug it through TSA whenever we went anywhere. And we've gotten down from this giant thing into a very compact little package that has a laptop attached to it, and then has the components of the computer and the video game within. So it's very compact and is very easy to travel now. So it can go from center to center, or we can ship to families' homes and ship back. So yeah, and then within our natural history study, we have done some where we had individuals play active, and then we took some of the more well-known measures as well. So we did some PROs, we had them do the Northstar, had them do running tests, had them do arm tests, and we've looked at correlations between those as well. So, yeah.
Laurent?
So yes, we have several natural history studies ongoing. The biggest one is what we call Actiliage Next, that collects data not only in Belgium, but in Poland, in Czech Republic, in Romania, and in Egypt. And we have a lot of patients also from Egypt. But we have also all the placebo, the patients from the placebo group, and I think that there are a lot of pharma in the room, and that's my call, for the possibility to use the data, not only for our measure, but for all measures, to use the data from the placebo group. It is such a commitment that the families have done to be part of a trial where there is a placebo. If we could squeeze this data, if we could use this effort and to take all the information we can, we would be stronger as a community. And so the second question is the possible translation to clinical care and individual follow-up. My vision is really to develop a digital biomarker growth chart. Rather, you know, I'm a stupid and basic pediatrician, so I used to spend my life to fill a growth chart, right? We could have growth chart of digital measures to have an evolution of our patients over time, and to be able exactly to see if our intervention is changing the life of the patient, of the very patient who is in front of us, not of a group, but the patient who is in front of us. If it's about growth, I use a growth chart. I could do the same with a digital biomarker.
Yeah, and I think that's important to point out, because the 95% stride velocity is an outcome measure. It's not the device that Laurent's necessarily wearing. And so one of those things is, you know, people always ask me, can this be can someone wear a actigraph or an Apple Watch and they get a velocity? Does that translate? And so I'm curious if you've done that kind of comparison with other fit for purpose.
So you can measure stride velocity and percentile with whatever you want, a cucumber if you wish, but a banana. But the question is the precision, right?
Yep.
So EMA gave a very clear definition of the level of precision that you need to reach to get the measure. And if you don't reach this precision, then it's not supposed to be valid.
Yeah. Thank you so much. And with that, I need to end this session, but I think for us to keep in mind when you're looking at outcome measures, even the traditional ones, it's the approach and how you look at it. May it be just a time, you can look at rate, you can look rate of change, and then I would hope that all of us on stage and all those who are being innovative to be able to work together in a pre-competitive space for us to move this needle, because there's a new natural history coming and we have to be prepared for it. So thank you so much to the panelists. You did a wonderful job, and I will then hand it over to Rachel.
All right. Thank you so much, speakers. That was fantastic. Did you guys learn something? I learned a little bit about Taylor Swift, so there's that. My team gets mad at me that I'm not a Swiftie, but that's neither here nor there. We are going to pivot to some live polling, so I need you all to pull out your phones, iPads, laptops, whatever, and go to pollev.com/PPMD. Whoa. And once you get that pulled up, I'll give you just a second. We will dig into a few polling questions related to the last couple of sessions that we've been able to work through as a group. All right. pollev.com/PPMD. All right, are we ready? Somebody give me a thumbs up that they've got it up. Is it working? Okay, cool. Let's do it. All right. So the first question, this is going to be a word cloud. What are you looking forward to most at this year's 30th annual PPMD conference? Is it the learning? Is it the research updates? You can still plug it in. pollev.com/PPMD. And you'll see this word cloud, it's responding actively to all of the different things that are going to come in. So those bigger words are things that more people are feeding into it. Good, I'm glad you got it working. Maybe it's the research, maybe it's the lazy river. These are all valid answers. What are you looking forward to most? All right, looks like we're starting to slow down, but I see some awesome words in the center of that cloud. Connecting, learning, research, families, treatments, new. There's just so much that we each receive when we come to this meeting, and it's different for everybody, and that's the beauty of it, truly. We'll go ahead and let's move on to the next question. All right, so what are you most excited about with the new potential outcome measures? So this last session, we learned a lot about some of these new measures that are in development and being validated. Is it the ability to capture data remotely that excites you the most? Is it measuring things other than strength? Is it outcomes related to the quality of life? What really resonates with you? Outcomes related to the quality of life overwhelmingly. I think that says a lot. I think that really says a lot. All right, let's go on to our third polling question. We have another word cloud. What does stability mean to you? We obviously just had a session about physical therapy and outcome measures. The session before that, we were talking about these new treatments. But what does stability mean to you? I don't want to tell you what it means to me because I don't want to influence you. Progression, peace. I really like to see that one there at the center, peace. I think that's really insightful. Maintaining, function, quality, life, strength. These are some really spectacular words. Awesome. Lots about progression, maintaining, quality of life. Very good. Awesome. I love this. Oh, we got a thumbs up. I didn't know we had emoji input. Okay. Thumbs up. Very good. All right. Looks like we're seeing a little less movement. So I think we're flying through these. You all are overachievers. So we have one more question. We can go ahead and move on to that last question. What is the first theme park to open in Orlando? I've been to like one of these. A couple of them I didn't know existed, but maybe that's just because I'm from Ohio. Okay, so definitely not Universal, according to this group. 48% at Gatorland. All right, well, surprise, the Gatorland respondents were correct. Gatorland was the very first theme park to open in Orlando. So I know the families, a lot of you have brought your little ones or other extended family members and might be planning to hit the parks while you're here or after. So maybe hit Gatorland while you're in town. What's that? I don't know. Your guess is as good as mine. But all right, cool. Well, thank you so much for your input. I think that those couple of word clouds were really helpful. I think that data on what is important to you about outcome measures is really, really important. And it speaks volumes to not only where our researchers are, but where you are and what you value. And I think that that's really helpful feedback for all of our academicians and clinicians and researchers that are in the room. So I think I might be a little bit ahead of schedule, which doesn't happen too often around here, but we're going to roll with it. I'm really excited to welcome Pat back to the stage, and I will let her introduce this next session and frame the conversation. So Pat, I'm going to go ahead and hand things over.